to see such a full room for the first talk of the day. So what we're going to be going over this morning is diastolic function, and I'm going to be talking about doing the exam and the measurements that you will be doing to do a full diastolic assessment. So, of course, you want to start off, you really want to have high quality imaging. So you want to start off with timing with the electrical, timing and the mechanical of the Doppler signals. Your sample volume size is very important, and where that sample volume is placed. Gains in filter settings, even the sweep speed that you run your Doppler flows at, and if you would be doing a patient that you were looking for pericardial disease using a respirometer. But in most exams, even for diastolic, you want to know what the LV function is. So you want to get your best assessment of that, and if you have the capabilities of doing three-dimensional echoes in your lab to get the adequate volumes and wall thickness. And then LA volumes are very important. So what you're going to do is, what we do is to get an LA index is we do a 4-chamber view and a 2-chamber view, and we're looking at the difference here and coming up with the LA index with the volume. So that's very important in diastolic function, knowing if the patient has a normal LA size or not. And when you're tracing your atriums, you want to make sure that you're not going into the pulmonary vein or that you're taking in the left atrial appendage as part of the size. So for the left ventricular assessment, you're going to be looking at mitral valve inflow, because that's going to be looking at telling you about pressures from the atrium to the ventricle. We're also going to be looking at the pulmonary vein flow and color flow, MO propagation, and tissue Doppler velocities. And those are going to be, some of these things are going to be talked a little bit more in depth throughout the morning. So for the mitral valve inflow, you're going to use an apical 4-chamber view. You're going to put your color flow on for optimal alignment so that you're parallel with flow. And the sample volume size should be between 1 and 3 millimeters, and you want to place that at the leaflet tips. You want to optimize your spectral gain in your wall filters. And depending on if you were to be doing a respirometer study and you're looking for the difference of inspiration and expiration, you would want your sweep speed to be slow. Otherwise, you're going to be running at 50 millimeters or 100.
So the sample size is when you're doing the inflow and all that stuff, usually when you do your scale and all that, it should be at 3, is what she means.
So what we're going to be measuring with the mitral valve inflow is your peak E wave, the A wave, and your A wave duration, your E to A ratio, your deceleration time, and also in this you could be doing your isovolumic relaxation time. Of course, there are limitations, which would be sinus tachycardia, conduction system disease, and arrhythmias. The patterns that we'll be looking for are normal, impaired relaxation, pseudo-normal, and restrictive filling. So here's an example of a 4-chamber view. You can see that we're aligned with the color here. And if you look here, you want that sample volume to be at the leaflet tips. If you looked here, down here to the left, what's happened here is that sample volume is placed a little bit farther into the ventricle. So what that does is it grows your E wave. Taking that sample volume and moving it down closer to the leaflet tips, you can see here the ratio, the E is less than the A, so that is showing you how important it is to have correct sample volume placement. So what we're measuring here is the E wave. You want a nice crisp signal, that sample volume size between 1 to 3 millimeters, placed at the leaflet tips. So we're measuring that peak E velocity, the peak A, and then the deceleration time of flow from the E down to the baseline here. Also from this, you're looking at your A wave duration. So we're looking at early diastole, the pressure gradients between the LA and LV with your E wave, and late diastole, the pressure gradients difference between your LA and LV with your A wave. And then we're measuring your duration here of your A wave. So then you're going to look at your pulmonary vein flow, again in the apical 4-chamber view. Use your color flow again to align, and usually we're looking at the right upper pulmonary vein. Sample volume size actually that should be between 3 and 4 millimeters. Placed about 0.5 centimeters into the vein. You want to optimize the wall filters until the onset and the cessation of atrial reversal is displayed, and your sweep speed between 50 to 100 millimeters a second. From the pulmonary vein measurements, you're going to look at your S, or your systolic, and your D, your diastolic velocities. You're going to look at the ratio. You're going to look at your peak atrial reversal velocity and look at the time difference between atrial reversal duration and the mitral A wave duration. Of course, there's limitations. The atrial reversal velocity can be obscured by atrial contraction and affected by cardiac rhythm. So here's an example of the pulmonary veins trying to align with the color into the pulmonary vein. And sometimes what I even find with this, because it can be difficult when there's tiny little veins or you have a patient that's a heavy breather, you sometimes really have to use your breathing techniques to bring these in, and sometimes even zooming in on that pulmonary vein and even dropping the color scale to really see the flow in it before you place your sample volume in there. But as you can see, this is not a real clear signal. So what's happening here is this is not placed enough into the pulmonary vein. So it's very hard to see the difference between systole and diastole here. It's a very shaggy looking spectral display. So here clearly you can see, zoomed a little bit more into that pulmonary vein, you see that nice red flow coming into the atrium. You're going to take that sample volume and place it a couple centimeters right in there and look at the difference now at looking at that flow profile. You see a nice S wave in systole, you see your diastolic waveform, you see your atrial reversal here, you see the beginning of it and the end of it. So as you can see, it's so important to have all your Doppler filters and your scale, everything set just properly. Here's also an example of what you're going to see is, you don't see this all the time, but there's actually an S1, systole 1, and an S2, and then diastole. We measure S2. We're not measuring S1 because the S2 is relating to the stroke volume. Also, we're going to look at isovolumic relaxation time, and you're going to go between a 5-chamber and a 4-chamber view, and you're going to align between the aortic and mitral valves, and you can use either continuous wave or pulse wave. Sometimes I find it easier that you see the click, the closing and opening a little bit better with the continuous wave. You're going to measure the time from the aortic valve closure to the mitral valve opening. And of course, there's limitations to all this. By itself, it has limited accuracy. So that's going to kind of go along with some of the other measurements that you are doing. So here you can see a nice crisp signal of the closing and the opening here of the mitral valve. So that's the timing that you're going to be looking at. That's a repeat there. And then we're also going to be looking at color M mode, and you're going to use, and as you notice, all of this is being done from the apical 4-chamber view. You're going to be putting your color on. Again, this is looking at the flow propagating through the ventricle. You're going to decrease your depth to look and include the entire left ventricle and just the base of the LA with color flow. And your M mode cursor placed in the center of the LV and a baseline shift to lower the Nyquist limit. Down here. So here's an example here. So you can see that the baseline shift was moved up so that you can see this flow propagating from the atrium into the ventricle and looking at the time of how quick this flow is coming into the ventricle. And you're going to be measuring here the slope, the aliasing here at the baseline, measuring that up about 4 centimeters into the ventricle, and this is that's giving you your slope here. Go back to that. And then next we're going to look at pulse wave Doppler tissue, and I know Matt's going to be going over this in his whole entire talk. So you're going to use apical 4-chamber view, looking at your septal and lateral wall, sample volume here between 5 and 10 millimeters, and that's placed at or within a centimeter of the mitral leaflet insertion sites. You want to optimize your gain and filter settings and minimize angulation. Your velocity scale between 20 centimeters a second above and below the baseline, and your sweep speed 50 to 100 millimeters a second. So the measurements from this is you're going to look at your early E diastolic velocities and average septal and lateral velocities and calculate your E over E prime. The limitations is your E prime is reduced with surgical rings, prosthetic valves, annular calcification, and mitral stenosis. The E primes increase with moderate mitral regurgitation and greater. So here's an example of trying to align up nice and parallel here, and this gets a little bit difficult in the big baggy ventricles. You're going to kind of want to angle around so that you're getting the angle nice and parallel with the annulus, trying to place that right on the annulus so that you get nice, clean, crisp signals. You can see here this isn't crisp enough. You're having a hard time telling what your waveforms are here. And the difference here is just by cleaning that up with your gains and your filters, you can clearly see isovolumic contraction, you can see systole, you can see your E wave, and you can see an A wave here, so you can see your E prime here. And what you're going to do with that, I'm sure Matt's going to get into this, is you're going to be looking at your E over E prime with that. And this is looking at when we're trying to see the restrictive filling patterns, and if something is pseudo-normal, this is one of the measurements that's very important to do, and averaging both the septal and lateral. Also, to do a complete exam to try to distinguish a normal flow from a pseudo-normal flow, you're going to be using a Valsalva maneuver, because that decreases the preload during the strain phase. You want to have forceful expiration to generate an increase in the intrathoracic pressure. And this can be difficult at times to accomplish this maneuver. I usually kind of do a little practice run with the patient, trying to explain what you're doing, have them really push. I really tell them to push down with their stomach, like they're pushing it into the bed. You want to maintain the sample volume placement, and you're looking for a decrease of about 20 centimeters a second in the peak mitral valve E velocity and a prolongation of the deceleration time. And the limitation is that this can be difficult to perform. So here you can see an example of a patient at the ratio, look at the ratio here, the E and A wave, trying to distinguish, is this a normal mitral valve inflow pattern, or is it pseudo-normal? Because if you look at the pulmonary veins here, one view it looks, one display here, it looks almost blunted, and here they're equal. So you can see here, started the Valsalva maneuver, had them really bear down, and you can see what happens. You can see that decrease in the E wave. So this was a patient that actually was pseudo-normal. So this is where it's very important to use this maneuver to bring out the pseudo-normal versus the normal filling pattern. And what an excellent source to follow is looking at the guidelines and standards that's out there for BioSC, the consensus for the evaluation of the left ventricular diastolic function. And this is what we refer to in our lab, and now for part of the accreditation for the labs,